Thank you very much, chairpersons, and thanks again to Dr. Girk for inviting me. And I mentioned earlier, it's also been sponsored by the MDS. And those of you who are not members of the MDS should consider becoming that. So when you read books, they will show you NMDA, a big list of things, Casper-2, a big list of things. But the patient doesn't come to you with a thing written on his head, I have an MDA. So you have to think about where you should be suspecting an immune-mediated movement disorder condition. So obviously temporal evolution, a rapid development of symptoms. But I want to stress this, a new onset of psychosis, a new onset of cognitive problem or seizures should alert you to consider the possibility of an autoimmune movement disorder. And of course, specific type of syndrome like stiff person, a propensity to autoimmunity in the patient or the family, and a history or suspicion of a neoplastic process, because a number of the autoimmune disorders are paraneoplastic. But before we come to that, I just want to sort of point out that these are two sort of, particularly the first one by Ballant and Brain, is really an iconic paper. So if you want to sort of look up more details about these conditions, I would refer you to this paper. And before we come to the actual nitty-gritty of this, I just want to tell you a little concepts about autoimmunity. So when you're thinking about autoimmunity, you think about it in this way. So there are intracellular cytoplasmic nuclear antigens, like many of your paraneoplastic conditions, anti-Hu, etc. These are T-cell mediated. And the response to treatment with immune modifying treatments is not very good. There's a very high tumor association. The second group is your intracellular synaptic antigens. So anti-GAD, for example, in stiff person or ampifycin, these are intracellular. And here it's a sort of a mixed picture. And they may have a bit of response to treatment, but again, not as good as the neuronal surface antigens. And the classic forms here are the NMDA, Casper-2, LGI1, DPPX, and of course, new ones are coming around. And I'm going to concentrate in this talk mainly on the neuronal surface antigens. As I said to you, this is a more later version of the same graph, and you can see many more new antibodies have appeared. But we are going to stick to the main forms, the classic forms, which are the more common forms with regard to neuronal surface antigen antibodies. So these are the ones we are going to be talking about today. So let's start with the spectrum of NMDA antibody-mediated disorders. This is our own resident, and the story is very interesting that she didn't turn up for her ward rounds. And we were told that she had been a bit agitated a few days earlier. She didn't turn up. People went to her house. She was unconscious, and she was doing these movements. And I've shown this video a number of times. But I want you to pick this movement disorder in your mind. She's unconscious, and yet she's making anti-gravity movements. The second part is the perioral and the tongue, and the third part is the eyes. These three in an unconscious person, particularly a woman, a young woman, should make you think about NMDA. And they may have had the previous prodrome, which is a psychiatric prodrome. And of course, when you get clinical improvement, it also goes back the other way. The movement disorder gets better first, and the psychosis and psychiatric disturbance. And of course, you're concerned about teratomas and so on. You get this only in young people. So after the age of 50, don't go around sending an MDA. You don't get it after the age of 50. It's in the young people, in female more than males, and in female with tumor, but also with non-tumor. And NMDA has now become the most important encephalitis. It surpasses the viral etiologies and of other conditions like enterovirus, HSV, etc. So this is the most important encephalitis in young children and young people, which you should have a very high index of suspicion and think about. Children tend to be a bit different from adults. So they have more of a movement disorder, sometimes only a pure movement disorder, without having the psychosis, etc., which you see in the adult population. And this is a couple of patients here. Now, they may therefore resemble Sydenham's chorea. Some of them also have a high increased ASO titer. But the clue here is that they will usually have some other feature apart from having the chorea, either epilepsy or ataxia. So if you're seeing somebody whom you think has Sydenham's chorea but has epilepsy, keep in mind that this could be an NMDA encephalitis. The other place where you want to keep in mind is post-herpes simplex encephalitis. They've had their herpes simplex encephalitis. They now have a recurrence, and you think it's due to the herpes encephalitis relapse. But actually, this is due to a NMDA encephalitis because herpes simplex triggers brain autoimmunity, and that causes NMDA antibody encephalitis as a second hit in somebody with HSV. So this is another place you want to keep in mind. Very rarely you will get people with isolated movement disorder. For example, this lady here has a very typical little blepharospasm and cervical dystonia, but this is very uncommon. This is uncommon. The classic form I've already shown you. And if you're thinking about the classic form, and this is work we did with Sarosh Irani, and you're thinking about the NMDA antibody encephalitis, the movement disorder is very complex. But there are three features in the movement disorder which stand out. One is dystonia, so dystonic posturing, stereotypies, making stereotype movements, and a bit of chorea. So you never get tremor or tics as a manifestation of NMDA. It's the combination of the dystonia, chorea, and stereotypies which is the main feature in these people. And it also affects mammals. So this is a very famous bear called Nut. He's a polar bear, and he has his own website, and people were watching him in this zoo, and you see he's now suddenly having this rotatory behavior, and he falls into the pool and dies. And it turned out that he had NMDA antibodies. So that's the take-home message for you. The classic form, new onset psychosis, then the fairly typical movement disorder. Children, sometimes with isolated movement disorder, such looking like Sydenham's to you, but they will have ataxia or seizures. Consider NMDA in relapses of HSV. Consider NMDA in new onset, rapidly progressive behavioral problems or cognitive issues in a young adult, rarely in isolated craniocervical dystonia, and can happen in mammals. The next one is LGI1, Caspar2, what used to be called voltage-gated potassium channel antibodies. And the classic form in LGI1 is a limbic encephalitis, and the classic form in Caspar2 is neuromyotonia, myokymia, Morvan's chorea. These are the classic forms. But the phenotype has expanded. So you can get this in a paraneoplastic cerebellar ataxia, sometimes also with a peripheral neuropathy, a painful peripheral neuropathy. So somebody coming to you with a new onset of cerebellar ataxia with a peripheral neuropathy, keep in mind the possibility of Caspar2. It can also present with an isolated chorea, sometimes combined with behavioral and cognitive issues in an elderly person. So you might be thinking about Huntington's disease, but actually it's Caspar2. So this is a very important caveat to keep in mind, that it can come in an old person with a chorea and cognitive disturbance. So this is a man with just 3-year history of chorea. And of course, the classic form, which we now all recognize, and you should recognize, is this, the faciobrachial dystonic seizures, which you see here in this woman. And this is classic. You can see this recurrently happening in these people. They are mislabeled as functional or something, anxiety, and so on. And if you don't pick them up at this stage, they go into a full-blown limbic encephalitis. So you must pick them up at this stage. And sometimes these can look very bizarre. Like this is a Sardarji gentleman, a Sikh gentleman. Watch that hand. That's his first seizure there. That one, okay? And now he'll go into a more pronounced, there, see the seizure there in that hand? And then he goes into the other side and can have very bizarre appearing episodes. Again, labeled as functional, because people don't pick this up because the EEG is normal in that people. The MRI is normal at that particular stage. So people say, this is bizarre. This cannot be right. This is a functional. So, and again, it can happen in mammals. So this is a cat with LGI1 antibodies. She's drooling. She's got a movement disorder as well. Another one to remember is that it's just not the hand and the arm. Some of these people, it also affects the legs, and they can tend to fall. So unexplained falls in an adult. So this guy has had injuries here, as you can see, and he was labeled as functional. He was falling because his fatiobrachial was not just fatiobrachial, it was also involving the leg. So you can get involvement of the leg, and you can get longer attacks, as you saw in that Sardarji, which was thought to be functional. Two little red flags to keep in mind: that you can get prodromal episodic bradycardia. So you do an ECG in them, because you can pick up bradycardia. And second is hyponatremia. So if you're suspecting this, send their electrolytes, and you can get hyponatremia, and that can be associated with the LGI1 antibodies. The third one, this is very important, because these people come to you looking like CJD. They even have the abnormality in the MRI scan with the DWI hyperintensity, as you can see over here. So you are thinking this is definitely prion disease, but it is actually due to Caspar-2 or LGI1, and this can be even associated with an elevated 14-3-3 protein in the CSF. So in anyone with rapidly progressive myoclonus, seizures, cognitive decline, apart from prion, think about voltage-gated potassium channel antibodies, because it's treatable while prion is not. And talking about myoclonus, you also get recently described orthostatic myoclonus. So these are people who get myoclonus only in the legs. It looks like the people with post-anoxic myoclonus. So you get this negative myoclonus in the leg, and they sort of bounce down, and sometimes they fall. And I showed you that guy with the fall with the head injuries. So this little subtle giveaway myoclonus in the knees is related to Caspar-2. So it's called orthostatic myoclonus, meaning myoclonus which only happens when they are standing. So this is a spectrum of LGI1 and Caspar-2, a take-home message. Peripheral myokymia, hyperexcitability, what we used to call the benign fasciculation twitch syndrome, myokymia, Morwan's fibrillary chorea, thymoma. Look for thymoma in these people. And then isolated movement disorder like chorea, but also with limbic encephalitis. I showed you that old man. Orthostatic myoclonus, the classic fatiobrachial dystonic seizures, but keep in mind drop attacks, keep in mind hyponatremia, keep in mind episodic bradycardia, a CJD-like presentation, and then a painful neuropathy and ataxia. So this is the spectrum of the recent, and there may be more things which will be added, but this is the spectrum of LGI1, Caspar-2 at the moment. So we are still here. So we've done NMDA, we've done Caspar-2, LGI1, and now I'm moving to DPPX. This is rare. So this is another surface antibody, and this is a patient I saw very recently who was referred to as, he was actually in the psychiatry ward, and I was taking her around and told me, do you mind just having a look at this patient? He's funny because he set fire to his school, and he was arrested, and they found that he has funny jerks, and the jerks involved his trunk. Don't worry, I think it'll turn around. Maybe it will not. Okay. So he's talking about this. He had lost a huge amount of weight. So he had psychosis, set his school to fire, developed myoclonic jerks, and also a bit of chorea, lost a huge amount of weight. Some of these people get diarrhea, but he did not have diarrhea. He lost weight even without diarrhea. Okay. So these people have hyperexcitability, agitation, confusion, myoclonus, CSF may show lymphocytosis. So you're thinking this is an encephalitis. Diarrhea and weight loss is a very significant feature in these people, which you need to keep in mind in this. And the reason why you get diarrhea is because the antibodies also affect the gut apart from affecting the brain neurons. And they can present with a progressive myoclonus and rigidity, something like a stiff person syndrome, but with a lot of hyperexcitability in the trunk. So even if just doing a little on their back, and these sort of taps cause them to jerk. If you blow on their back, they will jerk. So there's a little touch there, they jerk. So very sensitive to touch the myoclonus, but on the trunk, different from stimulus-sensitive myoclonus, which you get in the hands in cortical myoclonus. And here he is better after treatment. So just continuing with the jerk theme, this is a lady with startle, okay? So you'll hear a noise and she startles. She never had this before. And now she realized that when there is a car passing, something is happening, she gets a jerk and a spasm. And again, you need to do the head retraction jerk. You tap them on the head or the face, they get this jerk, okay? So this is a startle response starting in the first time in an adult. And this is related to glycine receptor antibodies. So keep in mind DPPX, keep in mind glycine receptor antibodies, a new onset startle and jerks on touch and the head retraction jerk. Okay? And then lastly, we move to this, which we heard a little bit about the other day in the video session, about IGLUN5 antibodies. This is the most exciting area because it's on the interface between autoimmunity and neurodegeneration. So this is a patient who was the first patient described by Dalmau's group, and you can see he's got these little finalistic movements which he's doing. These are different from the RBD, where they shout and jump out. Here they are doing their task, whatever he's eating, he's drinking, and so on. And this guy had REM and non-REM sleep disorder, which was related to IGLUN5. And IGLUN5 is a disorder which happens in older people. So this comes in the age groups between 50 and 70. The disease duration can be long because unlike the usual antibody conditions, the disease duration can be up to 12 years. And when you look at their pathology in the people who died, they have a 3 to 4 repeat tauopathy, which is mainly in the hypothalamus and the brainstem. And because it is in the hypothalamus and brainstem, they have a lot of sleep problems. So they have stridor, sleep apnea, they have drowsy during the day, they have these abnormal eye movements. So they can come to you with ataxia and abnormality in their eye movements. They can come to you with Parkinsonism and a vertical gaze palsy, so you think it's PSP. They have cognitive deterioration, they have autonomic features, so you think it's MSA, because they also have stridor. And a number of these people, as I tell you, the sleep disorder is a very crucial thing which you need to pick up in these people, and the widespread is. So this is an example of what happens. She's sleeping and she's talking in her sleep. And here she gets stridor. Hope we can hear it. Not very good. Anyway, believe me, they get stridor. Usually the imaging is normal, but in some people you can get this sort of imaging where there is involvement of the brainstem and also in the thalamic areas and sometimes in the cerebellum as well. And just to sort of show that this spectrum is widening, see this lady. She presented with facial myokymia, which you can see on her head. Okay? But in addition, she had this myorrhythmia of the jaw. Now, normally when you see myorrhythmia of the jaw like that, you will say Whipple's. A slow myorrhythmia of the jaw, you say Whipple's. But she has the sleep disorder, that same sleep disorder with these finalistic movements. And then they did the IGLUN5 antibodies, and she was IGLUN5. And this is another treatable disorder causing myorrhythmia of the jaw apart from Whipple's. And this lady recovered with treatment. This thing about the head drops, which you get, sleeping during the day, head drops. You know, when you're sleepy, in the train you watch people and they're having these atonic head drops. This is very common in these people. And here, after treatment, he's completely okay. This was given to me by Pankaj Agarwal. His voice is okay, his head drops have gone. And patients will respond to immunotherapy. So you see this before immunotherapy, this lady, she looks like PSP. She has ptosis, hoarseness, dysprosody. You see the ptosis there. She can't walk. You'll see her walking. And she's got a vertical supranuclear gaze palsy. So she was diagnosed as PSP. But in PSP, you do not get the RBD type of features. So because she had the sleep disorder, You can see the gait instability and so on, and she needs help to walk. And here she is after immunotherapy, much improved. Not completely okay, but much improved. And here's another one who presented with a corticobasal syndrome. Okay, and she had difficulty with the left side, she had apraxia, and then she turned out to have IGLUN-5 antibodies. They treated her, her apraxia got better, but not just she got better, her DAT scan got better. So these are DAT scan here and see the DAT scan there. So there was an improvement in the abnormal DAT scan following treatment in these people. So this is the spectrum: a sleep disorder, REM, non-REM, stridor, phenolystic movements, sleep apnea. And the movement disorder can be anything: ataxia, chorea, Parkinsonism. So that's why you may be suspecting it in PSP, in corticobasal, in MSA, because of the autonomic features. Myokymia, myarrhythmia, like Whipple's disease of the jaw. And I'm sure we're going to find other types as well. So just 2 slides on management. In the people with the surface antigen, this is what I have showed you. First line immunotherapy, corticosteroids, plasma exchange, etc., can have an immediate impact, and therefore it's important to start treatment on these people. Second line, rituximab, cyclophosphamide, mycophenolate for more rigorous immunosuppression. But of course, there are more side effects with that. Very important, removal of a tumor, if there is, for example, in the NMDA, and so on. And some of these people will have a good response, like LGI1 to steroids, while the NMDA require quite often a second-line immunotherapy, having responded initially, but they seem to go into relapse and you require a second-line immunotherapy in them. So in conclusion, the spectrum of surface antigen-related antibodies has expanded. As clinicians, we need to be aware of these new forms because they are treatable. And many of these are responsive to immunotherapy, hence an early diagnosis. Early diagnosis is mandatory, particularly in, for example, faciobrachial dystonic seizures. You pick it up at that time, they respond. When they go into a full-blown encephalitis, they can die. So you've got to pick it up at that time. And there are new variations of the classic presentations, but the core phenotypes still remain the most common. Thank you.
Thank you, Dr. Kailash Bhatia.